Hello, my name is Edgar Gonzalez, and today I will be talking about gating stress. Now, the first thing I want to touch on is why is gating beneficial to a nuclear medicine stress test? And basically, gated spec combines the evaluation of myocardial perfusion and left ventricular function within a single study. Gated spec provides valuable information like ejection fractions, polar maps, wall motion, and wall thickening. Now, gating also provides an effective way to differentiate true fixed defects from artifacts such as breast or diaphragmatic attenuation, as true defects will neither move or demonstrate wall thickening, and this will lead to an increase in the image specificity. Gating also helps correlate areas of focal hypokinesis or akinesis with actual perfusion, because if areas of no perfusion demonstrate wall motion, it is indicative of hibernating myocardium rather than an infarct. Wall motion and wall thickening are other ways that a physician can tell if there is vital myocardium despite seeing a perfusion defect on a scan. Now, how does gating actually work? Well, the computer divides the R2R interval from the ECG into equal subdivisions. Now, there are two choices for the frames per cycle or the subdivisions. You can go with 8 frames per cycle or 16 frames per cycle. And according to the American Society of Nuclear Cardiology guidelines, 8 frames per cycle is considered standard and 60 frames per cycle is optional. At the end of the study, there will be essentially 8 or 16 composite images representing the left ventricle as it undergoes one heartbeat, from diastole through systole. The data is collected and stored, and when it's processed, it creates a cine image of the myocardium that can be played back showing the contraction of the heart. Now, one thing to note is that if only 8 frames per cycle are used, the left ventricle ejection fraction will be 5% less than that if we were to use 16 frames per cycle. So just one thing to keep in mind. Now, determining the framing rate. Now, the framing rate is basically how long does each frame last. And you do that by number one, you want to determine the length of each heartbeat. And you do that by dividing 60 seconds by the patient's heart rate in beats per minute. So for example, if a patient has a heart rate of 90 beats per minute, you want to divide 60 seconds divided by 90 beats per minute, and that will give you 0.67 seconds per beat. Step number 2 is you want to divide that number, the length of the heartbeat, divided by the number of frames per cycle. So you will divide 0.67 seconds per beat divided by 8 frames per cycle, and that will give you 0.08 seconds per frame, or 83 milliseconds per frame. So each frame is made out of 83 millisecond images of the heart as it contracts. Another thing I want to talk about is the R2R window. The R2R window is another important camera setting that needs to be set properly. Now, this is usually done automatically by the computer, but a stable heart rate and rhythm can be achieved by rejecting the heartbeats that fall out of range. This beat length acceptance window can vary from 20% to 100% of the expected R2R duration. Now, there is no clear consensus on the acceptance window, but most guidelines suggest going with the 90 to 100% window because if the R2R window is set too narrow, good beats will be rejected, resulting in lost count statistics and ultimately resulting in poor image quality, which is a big no. Another thing we have to talk about is lead placement. Now, a 3-lead ECG is sufficient for the gated spec, but a 4-lead ECG can also be used. Proper lead placement and skin preparation is essential to obtaining a noise-free signal. Hair in the region of any electrode placement should be shaved and the sides cleaned with alcohol and gauze pads to remove any superficial dead skin and oils. Now, always check the screen of the ECG display before you begin the stress images in order to see if the leads are placed properly. If one or more leads are not placed properly, you will get a low voltage message on the screen or you will have to constantly be stopping during the acquisition of the stress images, which is very annoying. Now, another thing you have to consider when you're talking about ECGs are artifacts. And artifacts are distortions on the ECG baseline produced by factors other than the electrical activity of the heart. Artifacts can prolong the acquisition of stress pictures since it will reject most of the heartbeats and it will take a long time to accumulate the right number of beats. Now, some of the common causes of artifacts include poor skin contact, and that goes back to the last slide about lead placement, broken lead wires, patient movement or shivering, electrodes being placed on bony structures, skin folds, or seizures or Parkinson's disease. And so once again, always check your ECG before starting your stress pictures to see how your waves are looking. If the heart rate is off and the waves look weird, you probably have something messing with the electrical connection of the leads. Most common cause is patient movement, so have your patient rearrange a little or maybe rearrange the arms and try again. To conclude, gating is actually a very important aspect of myocardial perfusion imaging because gating provides valuable information for physicians like ejection fractions, polar maps, wall motion, and wall thickening. Gating is also important for differentiating patients' artifacts from true defects. And lastly, gating is useful for the evaluation of viable myocardium versus perfusion defects, leading to a more accurate diagnosis. This is my reference page, and thank you very much for your time.